Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thanks so much. This is just a follow-on on Brian Wood's talk from last week, right? That was focusing more on HIV treatment. There may be some overlap in some of the things that we shared. My disclosures, I just wanted to put this up just that as of August of this year, these are the medicines that are currently approved for use as pre-exposure prophylaxis. As you know, we're now at 13 years of FTC TDF. In 2019, FTC TAF, or brand name Descovy, was approved for use in folks who are not at risk from vaginal sex. I was excited because the Purpose 1 information was shared, and my understanding was that they were going to the FDA for an expanded indication to include all populations at risk from sexual exposure. But my understanding from the folks at the company is that FDA declined to expand the indication based on this current data. So currently in 2025, we remain as limited in terms of the populations who can be prescribed FTC-TAF according to the FDA. 2021, we got the first injectable PrEP with long-acting cabotegravir, which I'll abbreviate as CAB-LA, CAB long-acting. And earlier, many of you were at David Spock's fabulous talk about a month ago, where lenacapavir was approved as brand name for prevention as Yes2Go for HIV prevention. And so I'm going to talk probably about some non-FDA approved strategies. This is our disclaimer. And then just the things that I thought were interesting that I'm going to touch on. There obviously was a lot more at this conference. So we're going to talk about a new agent for PrEP, and then I'll give you some updates about lenacapavir as PrEP. And then we'll talk a little bit about PrEP preferences, some information about pregnancy and feeding outcomes with injectable PrEP, and then just a little teaser about artificial intelligence and novel technologies for use in HIV prevention. We started talking about this last week, and I know that people are excited about thinking about this. So I just wanted to fill out my thoughts on AI in HIV prevention. These were the most sort of things that got the most buzz from the prevention side. And I think one of the things that people were most excited about is MK8527. This is a oral nucleoside reverse transcriptase translocation inhibitor like islatravir, which is not moving forward in prevention. You're going to see in my slides that I've put the talk title in quotes, and where I cite abstracts, they are at the bottom of the references. So just as a reminder, we're going to talk about phase 2 studies. So a reminder about what the different phases are. In phase 1, you're testing small numbers just to really sort of get some preliminary data about safety and dosage. In phase 2, you're testing a larger number of healthy controls usually to further assess safety, and maybe you can get some efficacy data. And it's really the large-scale trials happen in phase 3, and then phase 4 is post-marketing. So there are going to be a couple complicated slides that I'm going to show you. I won't go through all of the details, but basically this is the study design for this phase 2 study looking at MK8527. Again, this is done in adults who are at low risk of HIV exposure and seroconversion, and this is really just about dose finding. So in the study, there were 3 different doses that were looked at. They were 3 milligrams, 6 milligram, and 12 milligram. People studied for a short time, just a total of 20 weeks, and looking at adverse events and then pharmacokinetic outcomes. And this slide is looking at just comparing the 3 doses and placebo with the different relations of adverse events. These are graded according to a standard NIH, about 1 is mild, 2 to 3 more severe, and then a severe adverse event is something that requires hospitalization or significant risks. And what you can see, you really want to focus on what is thought to be maybe drug-related SAEs, because if someone had something that was not related, the investigator would mark it down as not related. So looking at the drug-related adverse events in this lighter line here, they're really the same regardless of the level and compared to placebo. This is also true if you're looking at what was thought to be drug-related severe adverse events. You can see sort of not statistically different, but the numbers are even higher in placebo. And drug discontinuations are really quite infrequent, regardless, again, of drug level. Looking at what these specifically were, again, even with placebo, you expect to see some adverse events. With this medicine, because of other class-related decreases in CD4 counts, they're really interested in looking at that. Again, no real differences seen. So the conclusions from the investigators was that this medicine was well tolerated, it was similar in safety as placebo, that the exposures, and I didn't show you the PK data, but that the levels that they saw were proportional to the dose. And these phase 3 trials are about to start. You can see that on clinicaltrials.gov. I think one of them may even be enrolling or close to enrolling. They're using an 11 milligram dose, which is not one of the dose levels that was studied in here, but that's what they're using, comparing it to oral FTC TDF. And the two studies are going to be the expressive trials. These are one that is women in sub-Saharan Africa, and expressive 11 is going to be people in San Francisco, North Carolina, and Texas. Moving on to lenacapavir, there was a lot about injectable PrEP implementation and excitement about lenacapavir from the PURPOSE studies. I'm just going to give you a snapshot of what those are. As I mentioned earlier, that lenacapavir was FDA approved as of June 18th of this year. On July 9th, the Global Fund secured an agreement with the company that makes lenacapavir to obtain len for 2 million people at cost. There are additional negotiations about manufacture that you can read in that news article. And then on the 14th, the World Health Organization came out with guidance recommending lenacapavir as a option for PrEP, and interestingly also recommend that point-of-care HIV testing is sufficient in PrEP implementation. And part of this, when I was talking to Cheryl Johnson, who does some of these recommendations, that it's really about funding changes and being able to implement PrEP in some way. Just a quick snapshot of some of the lenacapavir information that came out. This is a slide from PURPOSE 2, which was one of the studies that was used to support FDA approval, comparing lenacapavir to oral FTC TDF. One of the things when you look at this bullet down on the bottom right that says that most of these participants favored these twice yearly injections over daily pills, and of course, these are individuals who are in a study that was looking at efficacy of this. So these were people who were really interested in the idea of whether an injection twice a year could work, could be efficacious for PrEP. So I don't take as much sort of preference information in thinking about will the general population of people at risk for HIV want to be on twice yearly injections. Clearly, some people were. And so of these folks who, again, they didn't know they were on active medicine or not, what you can see in the left part of this slide are the people who preferred injections, and they perceived it mostly because of the convenience and the ability to do something that didn't require daily adherence. I don't know what to make of the perceived efficacy when this information wasn't available yet. On the right are the preferences for people who preferred daily pills, and the one that's highlighted is that the people who preferred daily pills, about half of them preferred because of concern about pain and discomfort, which is, as you know from David's talk, is the main side effect, getting injection site reactions from lenacapavir and the other injectable PrEP. That is all I'm going to share about that. But there are two studies that presented results of pregnancy safety from injectable PrEP. There are actually a few other abstracts related to pregnancy and lactation. So this first, we're going to talk about CAB-LA, and then we'll talk about lenacapavir. And in all of the efficacy studies, people could not be pregnant at the time of starting. So it was an exclusion criteria at baseline, but of course you cannot fully prevent people from becoming pregnant. And so in these initial studies determining efficacy, if you became pregnant, they would discontinue investigational drug. But in the open label extension of HPTN 084 was the study that was done to show efficacy. So in the open label extension, people who became pregnant were allowed to continue on, but they were reconsented. I'm going to show you some of the initial safety data. They did not present any of the PK data from HPTN 084, the open label extension. So this is looking at pregnancy outcomes by exposure. And what's in the yellow are people who were actively receiving CAB at the time they became pregnant. In the greenish olive color are people who became pregnant when they had received CAB in the past. And then in the blue turquoise color are people who never received any cabotegravir. And on the right of the slide in these boxes, you can see what the background rates of complications are in pregnancy in these populations. And interestingly, one of the things that you can see on the slide, although not different from baseline, is that people, for whatever reason, who had prior CAB exposure they had lower rates of full-time births, they had higher rates of spontaneous abortion, higher rates of elective abortion. Essentially, it's unclear why, if there's any real basis for this. But when you look at the difference between people who are actively continuing to receive cabotegravir or PrEP versus not receiving any cabotegravir, outcomes are completely the same. But full-time births are the same, preterm births are the same. There was a higher rate of stillbirths in people who are not receiving CAB. And so, again, considered to be safe and no impact on pregnancy outcomes. And looking at this a little bit more in depth in a slightly different way, again, people actively on CAB, previously on CAB, and no CAB, that the folks who are not on CAB had a non-significant, slightly earlier births. There were no differences in the proportion who were small for gestational age, and there were a few congenital abnormalities and early neonatal death in folks on CAB. But again, none of this is statistically significant, but this is early data as we start to provide CAB to participants who are pregnant, who are at risk for becoming pregnant. So that was CAB-LA. I'm now going to go through the PURPOSE study, which is lenacapavir. Again, same thing, that participants, in order to be eligible, could not be pregnant at baseline, but if participants became pregnant during the study, they were allowed to continue and reconsented. And they did a PK sub-study of folks at week 0, starting at the time that they became pregnant, again, through pregnancy, and did some samples of infant plasma and breast milk samples at the weeks that you can see there. So this is the number of pregnancies by arm, lenacapavir on the left, FTC-TAF in the middle, and FTC-TDF. Because again, if you remember, this PURPOSE 1 was a study that was intended to collect data on the efficacy of FTC-TAF on individuals who are at risk from vaginal sex. The number of confirmed pregnancies you see at the top, the births were really the same across. The number of live births were slightly higher in the lenacapavir group, and pregnancy losses lower in that group. And you can see the data here, as well as some of the congenital abnormalities. But again, it's really, the idea is that there was no difference in these groups. When they did, and I'm not going to show you the actual data for the PKs, but they were similar when they compared women during pregnancy and non-pregnant women, and comparing whether people received their injections in their abdomen versus their thigh during pregnancy. You could detect lenacapavir in breast milk at about half of the level you can find it in plasma, but the concentrations you could find in the infant plasma were about 1/100th of that in maternal plasma, so it doesn't cross the placenta very well. So their conclusions from the study is len was effective, safe, and well tolerated in pregnant and lactating participants. And then finally, I just wanted to touch on my interest in artificial intelligence as well. And just a note, this came up earlier, that many of this work in what we're calling artificial intelligence is really about large language models and not truly artificial intelligence. So they're mathematical probabilities based on language and not truly thinking models. But I just have included 3 abstract numbers here that I thought were interesting, that other people in the community have found interesting, including some work in mental health, as well as to provide HIV testing care. And I think I mentioned last week about an interesting New York Times article about individuals who are drawn into worsening mental health because of their interactions with these large language models. And Lori mentioned when she looked at this about someone talking about a suicide that was thought to be attributed to use of ChatGPT. So these are not perfect, but there is a lot of work being done into it. And I think we just need to be aware of both the work that's being done, but also the limitations of it as we move forward. I know that Brian is interested in this, and probably there'll be some session focused a little bit more in the future.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.